The New Zealand health system is decentralized, in which the Ministry of Health plays a stewardship role to lead the whole system and collaborate with local entities such as district health boards, or DHBs, primary health organizations, and national bodies. Health and disability systems are also regulated by the ministry to ensure patient safety. In addition to the ministry, DHBs are key players. They are responsible for protecting the health of their populations by developing strategies and monitoring performance. With ministry allocated funds based on the district's demographics, they must plan and purchase the services needed to serve their local population. The issue of provider and financer split is eliminated. DHBs are expected to collaborate with one another to improve community health. The nearly $25 billion total healthcare expenditure is made up of 80% public and 20% private funding. Public expenditure is financed predominantly through a general taxation. Also, a higher income means that you are obligated to contribute more in taxes. 83.9% is allocated to DHBs, with the remainder spent by the ministry on national services, purchasing, and administrative tasks. The amount received by DHBs is calculated with a preset formula based on demographic factors. DHBs then go on to purchase services from providers to ensure citizens in the district can receive free access to the services that they need. As a portion of the New Zealand healthcare system is funded through an out-of-pocket payment, there is a potential barrier to access for individuals with low income. A survey found that 22% of adults had not accessed care due to cost. These barriers have been recognized and steps have been taken to minimize service users' co-payments. Private health insurance is somewhat uncommon, with approximately 30% of adults using it to supplement their national coverage. Medications, adult dental care, and optometry are some of the healthcare services that are not covered completely through the public universal coverage, and therefore some individuals use private coverage to supplement the cost. Finally, the Accident Compensation Corporation is a government body providing a no-fault compensation scheme for medical costs related to personal injuries. This is funded by employer, employees, the self-employed, and car license levies. Overall, Kiwis have very good healthcare coverage, which provides them with good financial protection. DHBs are responsible for purchasing outpatient and inpatient services, including primary care, which is funded through a capitation scheme. Money is allocated to primary health organizations, with different rates applied to high-risk patients and the type of service. GPs are then paid by the number of patients seen. In secondary care, providers are paid through a fee-for-service scheme, in private care, or an annual salary in public care. Fee-for-service physicians may earn 4.9 times more than salaried physicians, as this scheme provides an incentive to treat more patients. However, this may be at the risk of quality. In contrast, fixed salaries may result in loss of productivity and turnover as physicians switch to the private sector to capitalize on the higher earning potential. Given the organizational and financial structure, there are several issues in the healthcare system. Despite decentralization decision-making to local districts, the Ministry of Health often interferes with DHB's operations, which constrains their local autonomy to meet community needs. Next, having 20 DHBs of different sizes results in poor interoperability between boards and issues with the current financial allocation model. Public health funding does not assist in reducing disparities in health outcomes, as capitation does not provide additional support for low-income groups. Last, the current financing structure may not be sustainable long-term against the projected increase in healthcare expenditure from 9.3% of GDP currently to 11% in 2060. This warrants financial revision. Public health services in New Zealand are largely provided by DHBs through DHB-owned public health units, covering primary care, specialized care, and acute care, and mental health care. The degree of accessibility is fair, resulting from capitation schemes, subsidized pharmacy, and community services. Overall, quality of services is satisfactory in terms of primary care and mental care, even though the number of physicians are less than the OECD average. The key issue would be poor dental care, reported in both adults and children, which is considered to be below OECD average. Health service provisions are considerably inequitable, especially for minority groups like Maori and Pacific people. Based on our analysis, we evaluate poor equity for all services from primary care to pharmacare. Despite community-based practices and publicly funded services, the Indigenous still have difficulty accessing their GP and report negative experience with treatment. Several contextual factors place pressure on the health system. For decades, health disparities between ethnic groups, specifically Indigenous groups, have been one of the most significant drivers. For the Maori population, social, cultural, and economic factors are the main underlying determinants of the poor health status, and across all socioeconomic predictors of health, including income, education, and employment, the non-Maori population is more advantaged than the Maori. Both Maori and Pacific Island populations are 2 to 3 times more likely to die of conditions that could have been avoided if proper care was provided. In regard to policymaking, New Zealand has made a concerted effort to measure and target inequalities, but issues related to mortality and morbidity among Maori groups persist. In a broader sense, demographic changes are similar to many developed countries. The aging population and social factors like unhealthy diets and limited exercise have contributed to the shift to non-communicable diseases and a higher dependency ratio. Furthermore, the chronic disease and comorbidities are a growing concern and will increase the demand for healthcare, especially long-term care. These factors are extremely relevant to the present-day healthcare system. However, the system and economy will be impacted by the changing environment and technology in the future. We can expect climate change to affect the social and environmental determinants of health, like extreme temperatures and poor air quality. The Ministry of Health is looking to adopt new digital solutions like telehealth, digital records, and e-medicine to improve the health services quality, performance, and access, ultimately challenging our conceptual concepts of healthcare. We found that New Zealand performs well overall. With a life expectancy of 80.2 and 83.6 for males and females respectively, New Zealand is slightly ahead of the OECD average and ranks 15th worldwide. Although per capita expenditure is lower, the 4 countries spend a similar percentage on their GDP on healthcare. 81.5% of patients report definite trust and confidence in their GP, further validating good performance. Data on physician experience is highly limited, but we did find that 50% of senior doctors and dentists feel burnt out, which should be investigated further. It is also noteworthy to readdress Indigenous populations, as there is a 7-year gap in life expectancy between Indigenous and non-Indigenous people. This disparity continues to prevail across the system, demonstrating poor performance in achieving equity. We can best understand the goals and challenges through the 10-year strategy released in 2016. This provides direction for how resources are allocated and how DHBs make decisions and deliver services. Managing the aging population, demands from long-term conditions, and high inequities among Indigenous groups are challenges highlighted in the strategy and directly align with what we have already identified and discussed in our contextual analysis. These 3 challenges are drivers of the 5 key goals outlined in the 10-year strategy. First, they want to encourage self-management by empowering people to make health-conscious decisions and reduce the burden on the larger system. Second, moving care to the community encourages integration and partnership with the other public services to deliver care. The third use of value-based outcomes to drive high performance motivates providers to constantly improve how they deliver care. Fourth, collaboration between patients, family members, clinicians, and researchers ensures nothing is overlooked and the best care is provided. Fifth and last, smart systems focus on developing and implementing technological innovation like information systems to improve clinical and operational aspects of care. After our analysis of the New Zealand healthcare system, we propose 3 recommendations that target key limitations found in the current system. These solutions are based off of proposed strategies in the literature and align with the existing health strategy goals to help ensure their success. It is clear that there are serious health inequities among Indigenous populations, and the existing strategies are not sufficient. We want to update the strategy by fully removing cost barriers associated with accessing care and focus on enhancing primary care. This is an opportunity to engage Indigenous populations and build trusting relationships, but requires significant cultural adjustments to the conventional primary care model. Lastly, the entire healthcare workforce needs to be educated on the cultural differences and how to best support Indigenous health. Next, it is essential for New Zealand to offer dental coverage to address current challenges. The dental problems can be better prevented by educating and promoting oral hygiene practices through community-based campaigns. Vulnerable groups in which the main inequities still exist should receive full coverage to reduce the impact of cost barriers, while the general public receives subsidized basic dental care. Last, the burden of NCDs and the aging population are common worldwide and a strain on healthcare resources. New Zealand can enhance integrated care by involving social and community care resources. This aligns the existing healthcare goals by ensuring the non-hospital bodies deliver in-resource care through self-management strategies and complementary tasks. By actioning these recommendations, we believe that the New Zealand healthcare system can address these three major concerns.